We have another rapid presentation from Hannah Aridi and the Indiana University Group. So this is entitled Beyond Race and Geography, Exploring Factors in Non-Traumatic Lower Extremity Amputations Through a Single Institution Analysis.
Good morning. My name is Hannah Aridi. I'm a resident at Indiana University School of Medicine. Although amputation is an important and potentially life-saving treatment option for some patients, it is often preventable even among patients with advanced PAD. Major amputations are associated with increased morbidity and mortality. They are expensive, even more expensive than revascularization, and they are significantly associated with a decrease in quality life scores. Race has been determined as a risk factor for CLTI-related major limb amputation and the underutilization of limb salvage techniques. Several studies have demonstrated that compared to other racial groups, African Americans have higher rates of PAD and other comorbidities. They have more severe disease at the time of presentation. They are less likely to be treated with optimal medical therapy or to undergo limb salvage therapy, and even if they do, they usually have worse outcomes after revascularization. We aim to identify factors associated with increased risk of lower extremity amputation in patients with critical limb-threatening ischemia at our institution. So a retrospective review of patients who were diagnosed with CLTI within a 5-year period, 2016 to 2020, was done. And we looked at patients who had a major amputation above knee or below knee within 5 years of diagnosis and matched them to those who did not based on age, sex, and race. We also geocoded home addresses to get some socioeconomic metrics, and the standard statistical analysis was used to identify. So in Indiana, the landscape is dramatically changing, but as you see in those maps, area deprivation index and household income varies significantly within our state, and usually patients coming from the most impoverished blocks live in areas interspersed among the wealthiest. In our prelim analysis, we had 3,000 patients diagnosed with CLTI in a 5-year period. Among those, 492, 16%, had a major lower extremity amputations within 5 years of their diagnosis. As expected, African American patients had significantly higher amputation rates compared to their white counterparts, and they usually had a more major amputation, meaning above-knee amputations. There were also significant differences among individual hospitals based on their location and the community they serve. Comparing patients who had a major amputation to those who did not, in terms of baseline characteristics, those who had a major amputation had more comorbidities, including diabetes, cardiac comorbidity, dialysis, CKD. They were more likely to be smokers, but interestingly, they were less likely to be on optimal medical therapy, such as antiplatelets, statins, or anticoagulation. 66% of patients who had a major amputation after their CLTI diagnosis were diagnosed with CLTI in an inpatient setting, compared to 72% of patients who had no major amputation who were diagnosed in an office or an outpatient setting. There were no differences in socioeconomic factors between the two groups. On multivariable analysis, significant predictors of amputation, independent of the factors we matched on, such as race, sex, and age, showed that diabetes, dialysis, cardiac comorbidities were significantly associated with a risk of amputation. Not being on optimal medical therapy was also associated with increased risk of amputation. However, the strongest risk factor was an in-hospital diagnosis of CLTI, which was associated with a 9 times the odds of a major amputation compared to an office or outpatient-based setting. So our analysis, although preliminary, brings attention to the significant issue of limited access to preventive care for patients with peripheral arterial disease. A considerable number of our patients who underwent a major amputation were diagnosed with CLTI while receiving inpatient care and were not receiving optimal medical therapy. The lack of association between major amputation and socioeconomic factors on the matched analysis highlights the interconnected influence of race and socioeconomic factors in determining the likelihood of major amputation, specifically in Indiana, where unfortunately most of our underrepresented minorities come from disadvantaged areas. Going forward with our project, we aim to include our VA population as it represents a significant portion of our CLTI patients and kind of a different population in terms of insurance and access to care. We are collecting more granular data, such as anatomic, specific vascular history, and primary care availability for those patients. And we have initiated a qualitative study to look at patients' and providers' perspective for the perceived challenges for CLTI care. Thank you.
Ted Gifford, Hartford Hospital, thank you for that talk and for all the work that you guys are doing. I know you have a lot of outreach efforts for limb preservation. How did you guys define CLTI? Because I think that's a variable where, you know, kind of came into the lexicon with the global vascular guidelines, which were after your initial start. And were you able to cross-reference patients with CLTI on their initial admission who also presented with wet gangrene? Because I think similar to the author's presentation yesterday on the unhoused population, there's a huge cohort of patients that are presenting with wet gangrene, essentially an unsalvageable limb. That's a different entity than patients who have CLTI and aren't getting the appropriate care once they're diagnosed with that to try to achieve limb salvage. Thank you.
Yeah, thank you. For our cohort, we relied on ICD-9 and ICD-10 codes to define CLTI, and we cross-referenced. And one of the main reasons we matched, because we had 492 patients with amputation, and we had like 2,000 plus patients with no amputations. So we literally went patient after patient, reviewed their chart, and made sure those patients are not like diabetics presenting with diabetic foot infection. They did have studies that confirmed a peripheral perfusion or poor peripheral perfusion and vascular studies. In terms of the wet gangrene, we are in, like, the project is ongoing, and we really want to get data on Wi-Fi scores, and this will kind of help us distinguish or eliminate those outliers.
Really nice work. This kind of mirrors similar to what Dr. Humphreys has done in terms of the vascular desert mapping and access to care. And so, you know, I guess my question is we're doing a really good job of presenting all this research on patients that don't have access to care, patients that aren't getting preventative medicine, that aren't on aspirin, statin. What do we do about it? You know, are you guys implementing anything at your institution to try to get these patients plugged in, get them access to care, get them on the preventative medicine that they need so that they don't develop CLTI? You know, how do we take this one step further into action items to actually make change?
Yeah. Thank you for this question. It's a very long journey, as most of you, like vascular surgeons, know. This is a quality improvement project that's based in our institution. We hope that by looking at our primary care physicians' perspectives into the challenges of CLTI to provide more education for our primary care. Like every year we do a vascular symposium, we invite like primary care physicians, cardiologists, just to educate them on like signs and symptoms of PAD, importance of early referral for those patients. But however, the road is so long, and there are ongoing outreach programs everywhere, and they usually overlap, but there needs to be more done in this area.
You got 10 seconds.
Yeah, just a real quick question. The time period was 2018 to 2022.
2016 to 2020. Sorry.
2016 to 2020. Okay, never mind.
Okay.
I missed it.
Cool, thanks.
All right.
I will just say briefly, you know, the ability to look at really granular details in a single center data set, I think can be very powerful. And instead of just looking at endpoints that we have traditionally, you know, reported on, I think it's really important to either look at process measures or define new process measures or novel process measures that might help us better care for these patients. For example, and this is just very, you know, off the top of my head, if someone has a hemoglobin A1C that's higher than their hemoglobin, they should be with an endocrinologist, right?
Yeah.
I think those simple rules, right?
Yeah.
Like that. But we have a lot of individuals who aren't, right? So I think simple things like that can help.
Like one of our variables is like looking, do they even have a primary care physician on file or a podiatrist if they have tissue loss, which is rare for many patients. Thank you.
Thank you.